I'm just going to jump straight in. Today we're going to be talking about bridging the divide between the GP and the pharmacy profession. Learning outcomes. Dupe is going to highlight the barriers between the GP and the pharmacy profession in primary care. I'll spend some time talking about us pharmacists, especially us in the grassroots, how we need to collaborate if we want others to collaborate with us. And then we'll spend the last few minutes exploring the role of a unified digital front door for community pharmacy to enable cross-professional collaboration. Over to you, Dupe.
Hi, everyone. So you're probably wondering who we are. So I'm Dupe Akomolafe. I'm a GP by profession, and I'd like to describe myself as a retired NHS GP. And I work solely in the private sector with my husband, Baba Akomolafe, who is a community pharmacist. So we run Christchurch Health Centre. It's a family-run business that incorporates Christchurch Clinics, Christchurch Pharmacy, and Christchurch Care Agency. We've been married for 25 years, as you can see. That's on the left, also on our wedding day, 25 years ago. And earlier on this year, we celebrated our 25th wedding anniversary. And I'm proud to say that's me in my original wedding dress, no Monjaro. I have absolutely nothing against Monjaro. I run a weight loss clinic, so I'm for Monjaro. And down there below is what the pharmacy press say about us. Dynamic duo, a marriage made in heaven. I beg to say that this is only possible because of a relationship that is working. The relationship it leads me to the relationship between our professions as GPs and community pharmacists. It is really a relationship like an arranged marriage. Think about it. The only problem is that it is such a poor arrangement. And that is why we have difficulty in primary care. It is a poorly arranged relationship. And why do I say so? We have segregation rather than integration. We have both professions working in isolation rather than in collaboration. We have competition going on between the sectors rather than us complementing each other. And there's duplication of work rather than us working in synergy. These things are not new. You all know this. It's happening. What has happened is that our contracts have been designed to compete with each other. We're competing for flu jabs. We're competing for COVID jabs. I've recently heard that some GP surgeries are sending text messages to their patients, discouraging them from attending their pharmacy for their flu jabs. These are pharmacies that they have built a relationship with over years, community pharmacies that they visit every month. And GPs are now saying, do not attend your pharmacy. This can't be right. We have funding issues that are completing. There's no joint incentive for us to collaborate. And that's where the problem is. We have, take duplication of work, for example. As pharmacists, you're doing NMS. As GPs, we're doing medication reviews. Who's doing what? We have platforms, clinical platforms that do not speak to each other. GPs cannot access pharmacy platforms, clinical platforms. Pharmacists cannot access GP patient records. And yet we're serving the same population. We're trying to achieve the same aim, trying to improve patient outcome. How can we do that when we're not actually even working in synergy? This is costing the NHS. It's costing the NHS in manpower. It's costing the NHS financially. And that leads me to something that Bagda and I passionately believe. The NHS is not broken. I know it's an audacious statement. It's one that politicians do not really believe. The NHS is not broken. I strongly believe that. I have worked in a system that is broken. And what you have is you have a patient at the beginning of their journey with needs, and the patient gets to the end of the journey with unmet needs. That is a broken system. It is a system where there is no structure there for the patient to receive the care that they require. In the NHS, you have a patient who starts their journey with needs. At the end, what you have is a patient whose needs are being met, but it's delayed. There's a delay in meeting those needs because there are long waiting times. That system is not broken. That is a system that is overstretched. It is a system whose workers are overwhelmed. It is not a broken system. Over to you, Baba.
Absolutely. Now, the NHS is broken is a statement you hear from politicians who are trying to get at the other party. But how do we feel as NHS workers who are overwhelmed being told that we're broken? We're not broken, we're overwhelmed, we're overstretched. GPs, pharmacists, we're under that pressure. The NHS is actually in deep need of strategic workload management. Now, I'm going to introduce you to three characters. Now, these three characters are real monkeys, right? Okay, you got Graham, Phoebe, and Phil. This actually happened in South Africa when we went for the Sigma conference. So the big monkey is in charge, right? The big monkey. Behind you got Phoebe and Phil trying to get in on the action. Okay, now Phoebe is making an attempt there. She's been able to grab one. And Phil is thinking, should I join in? Should I go and get mine? But instead, Phil is squabbling with Phil, trying to get some from Phil instead of going to Graham, who's got a lot on his plate. You may wonder, Baba, why have you brought me to Birmingham to look at monkeys? What if I told you to consider that GP Graham is actually the doctor who's got a lot on his plate, and Phoebe and Phil are me and you pharmacists in our neighborhoods, squabbling for ETPs, squabbling for nominations, when there is so much workload on the plate of GP Graham. So you understand the picture, is that okay? Right? Now, this is just in need of strategic workload management. The crisp you see there is actually work, it's not food. Every crisp you see there is a patient who wants to be seen by a clinician. They don't care. They just want their needs met. Now, you've got pharmacists who are trying to get clinical services. They've got the training, but they can't get on there. It's all on the place of the GP. Everything goes to GP first. But we say pharmacy first, but it goes to GP first. This is not right. So Dupe, tell us why we need to bridge the divide in primary care.
Yeah, thanks, Baba. So, GP Graham is non-binary. GP Graham was me for 20 years. GP Graham is my female colleagues, my male colleagues in the NHS. GP Graham is overstretched, is overwhelmed in an overstretched system, healthcare system. And what's happening is they can't cope. Now, this is even worse. The pressure is worse now since 1st of October when the access target became a new contractual obligation for the GPs. So now they have to keep their online appointments open, online access open throughout their contractual hours. You probably all know that in the past, when it reaches maximum capacity, they turn the online access off. Well, now they can't do that. That has to stay on throughout the contractual hours. I left the NHS 3 years ago because I had a choice. I had a choice to step into private practice full time. A lot of my colleagues don't have that choice. They're under pressure, constant pressure. Now, what's also happening is that we know about the government's plan, 10-year plan, the left shape. We're moving from hospital to community. from treatment to prevention in an already overstretched system. How can they cope without strategic workload management?
Okay. So what that means for me as a pharmacist is just like Phoebe and Phil, we are trained to provide pharmacy first. We are trained to provide IP services, independent prescribing, but we don't have access to this work, so we are underutilized, okay? Now, what we want to also consider is that GPs, pharmacy first has been made GP referral dependent, and we act as if referring a patient is not a job. So the GPs who's already under pressure is having to do that workload of referring patients with their staff and all of that before they actually start their work. We're going to see more analog signposting where the GPs are going to look at their workload. They know that 20 to 30% of their workload can be seen by a pharmacist. Instead of creating a referral, they're just going to say to the patients, go next door, or send an SMS to the patient saying, you can be seen by a pharmacist. That's going to put pressure on us because we don't know who's coming when. And that is something you don't want to handle. GPs have complained about that 8:30 pressure. Now we're going to have pharmacists 9 a.m. pressure, where patients are going to queue up, 10 of them who have been told by the pharmacist. Some of them have got buggies. Some of them are elderly people wanting to see the pharmacist at the same time. This is a lack of strategic workload management. In your businesses, you will not stand for that. Why should that be the case in the NHS? So I'm going to introduce you to a solution, and I pray that my colleague around the back is going to make this work for us. It's a video. There's just too much to be able to articulate in front of you. So we thought we'll put it in a 2-minute video. So please bear with us as you listen to what is on the video.
Introducing the ABC strategy in primary care. A simple yet strategic model for smarter workload distribution. A. AI Total Digital Clinical Triage. At the GP surgery, automated tools triage patients at the first point of contact. B. Booking via Community Pharmacy National Booking Service, CPNBS. Patients identified as suitable are signposted to a central booking platform to access pharmacy first services. C. Connection and collaboration. Digital tools like AccuRx, eConsult, Clinic ensure seamless communication between GPs and pharmacists. What is the current problem? Community pharmacy is digitally excluded from NHS infrastructure. Not listed on the NHS app as a clinical service provider. No centralized platform exists for GP referrals or patient-initiated bookings. The vision: build the digital front door for community pharmacy. If we build IT, they will come. Field of dreams. We propose a nationwide digital platform that aggregates real-time availability of community pharmacies using geolocation, enables patients to book pharmacy first appointments directly based on AI triage from their GP surgery, operates similarly to the National Booking Service, for example for COVID vaccines, without storing patient medical records, allows pharmacies to use their existing internal systems for managing the consultation. Immediate advantages of CPNBS. Reduces GP pressure. Up to 30% of patient requests can be diverted directly to community pharmacy. Restores patient choice. Patients can see and choose available appointments, reducing disappointment and failed walk-ins. Efficient referral filtering. Pharmacies can pre-screen bookings to ensure patients meet the pharmacy first gateway criteria. Geographical visibility. PCNs, neighborhood networks, and commissioners can see real-time capacity across regions, enabling targeted action on health inequalities. Data-driven negotiation tool. Real-time data gives Community Pharmacy England a powerful tool to negotiate funding and policy. Summary. A win-win strategy for the NHS. Patients get faster, more accessible care. GPs get breathing room and can meet contract access targets. Pharmacists gain autonomy and better workload control. The NHS becomes more efficient, equitable, and digitally connected.
You get the point. That's what's called strategic workload management. It will cost the NHS absolutely nothing because the workforce is already there, but the workflow isn't working. Imagine in your pharmacy, if every patient who comes through the door has to go through the pharmacist. Do you understand what I'm saying? Which of you has your front door leading to your master bedroom? It doesn't happen. Only in primary care. Everything goes through the GP surgery. Pharmacists have been digitally excluded from the NHS app. You can order your medication, but you cannot book an appointment with your pharmacist. You cannot make that pharmacy first choice. Now, if you say pharmacy first, how come you cannot book it digitally?
It's a misnomer.
It's a misnomer because everybody does everything digitally first. Now, so if we're excluded in that way, so what are we saying about the solution? I'm going to leave these points with you. Pharmacy needs a digital front door. I was at a meeting with AcuRx, and what they're doing is they're going to do a total digital triage of all the workload that comes into the GP surgery. There's going to be 20 to 30% of that workload that can go to other services, especially pharmacy. They're going to send those patients an SMS saying, find a pharmacy. When you go and find a pharmacy on the NHS website, what do you see? You see Christchurch Pharmacy, you see our name, you see our postcode and our opening times. You don't know if I'm available or not. How many pharmacists do we have here? Community pharmacists, right? Okay, so do you use the NBS for vaccination? Anybody does COVID vaccination, right? So the National Booking Service platform allows patients to see the availability of community pharmacists across the country. So if they want the COVID jab right now, they can find not just a pharmacy, but find an appointment. We need that for pharmacy first. Now, what we have done is Dupe and I have invested our time and energy with some friends of ours to actually set what is a prototype of what can solve this problem, a bridge, a digital bridge. I'm going to talk you through this demo. On that, you can see the 7 services. I'll just see what the speed is. With 7 conditions and minor ailments. The patient puts in their postcode for geolocation to find the pharmacy. On this occasion, the patient is actually in Braintree. And of course, when they do their search, they're going to search for the best pharmacy in Braintree, which is of course Christchurch Pharmacy. Sorry, I need to advertise myself. And in the platform, the pharmacist is the one who opens up their appointments. If you only have 2 hours for pharmacy first, you open 2 hours of appointment. When the patient goes in to choose and book, they choose and book the appointments that you've made available. They've not left home, remember? Now, there are no patient records kept on Community Pharmacy National Booking Service. It literally is a door. It does not replace Pharmacist, it does not replace Sona, it does not replace Surgedim or whatever system you use. It literally is going to allow the patient to send an SMS or an email to their pharmacy. So when they put their NHS number, which all of us know we can use in our pharmacies through our smart card to identify the patient. Okay, so you identify the patient and you've got their mobile number. Once the patient has put the condition they want to be seen for and their details, they will submit. That's the summary of what they want to submit. They submit that, and as you will see on the other mobile phone to the side, they receive a text from the system saying your appointment has been sent to the pharmacy. The pharmacy gets an email in the NHS email. You open the email and the pharmacist gets the opportunity to actually RSVP that request. Why? Because there are some people who will come in that you may need to say to them they don't qualify. In that scenario, the pharmacy will choose decline, and that gives the options. In between this time, the pharmacist has already sent a questionnaire, which all your systems have, saying to the patient, can you fill this form so I can verify that you feel you meet the gateway criteria? If they don't, at that point, the pharmacist will send a message to the patient saying, you don't qualify, and the patient gets a reply, an SMS, as you can see there, your appointment for 10 o'clock at Christchurch Pharmacy has been declined because. Remember, this patient has not left home. What we're having right now is an awkward system where the patient is told to come to the pharmacy, they get to me, I turn them away, they go back to the doctor's frustrated, the doctor is then frustrated and then doesn't want to send any more referrals. All of this in 2025 can be done on a mobile phone. Do you see what I'm saying? So that is what we call strategic workload management. The work there is enough, the workforce is there and is enough. We do not have a broken system, we have a system that is not well organized to maximize the use of the workforce, especially us pharmacists who are being underutilized in primary care. So Dupe and I are we're going to be at the networking zone, stand J38, 39 rather, to carry on the conversation. But if we can have the microphone go around, we're happy to take questions from yourself. Just let us know if you're a community pharmacist or commissioner, and then just gives us an idea of what, yeah, okay.